All right, hello and good evening. Let's go ahead and get some more people admitted in here. All right. Okay, go ahead and get your mics on mute just for a few more minutes. So mics be on mute just for a few more minutes, and then I'll give you guys the opportunity after we kind of talk about how the evening will go. I'll let you guys turn on. Awesome. Okay, so welcome. My name is Emily. I run the Facebook group you all found this through and have been doing so for almost 5 years now, just as a resource for students in nurse practitioner school. And we're going to get a couple more people admitted here. Okay. And so that was the whole point of why I made MP Guide a few years ago. As soon as I got done with school in 2018, I decided I wanted to take the time to create resources for other students. I realized that there was not a lot of resources out there that for students. There's lots of continuing education geared out there for people who are already graduated, a lot of continuing education. But I wanted to create companion courses for people who are going through school, for tutoring services for people who are in school, mentorship, and that kind of thing. So that's been what I've been doing. So tonight I wanted to do some case studies. Case studies are such an incredible way to learn. It's one of my absolute favorite things to use for learning, and that's why I've chosen to use that format tonight. So I'm going to take us through. We'll see how many we get through. Might be 2, might be 4. Don't know. Again, I'm leaving everybody on mute for now. So if you could please leave your mics off until we are ready to get started, where we'll be able to do some things like doing some feedback. So there will be times when I'll ask questions. There's also the chat feature, which is a great thing to use, especially if we end up having quite a number of people coming in. So you can use the chat box as well. So one thing I do like to have everybody put in the chat box is an introduction. So you can put where you're going to school, what term you're in, if you're towards the beginning or the end of your pathway, and then one thing you're hoping to learn tonight. So go ahead and put that in the chat if you would. Get started. I'm going to go ahead and pick our first case study and start screen sharing. All right, I have picked our first. So the resource that I use, I'll share my screen now. The resource that I use is this little book right here. Whenever I like to do case studies for students, when I'm doing mentorship, or when I'm doing a class like this. This is 101 Primary Care Case Studies. This is the first edition. I'm very excited that I will be contributing 3 case studies to the second edition, which will I'm not exactly sure the timeline of the publication of that book. I think it's next year, but I'm very excited to be writing for three case studies. I am so passionate about case studies. So this is the book, 101 Primary Care Case Studies. You can easily find that on Amazon or on the Springer Pub website right here if you want to get it. I find it to be an incredible resource because when you go down here, there's this show answer section where it is so detailed, whereas a lot of the other case study books that I've previously purchased and used did not have a really good answer key. But since it's contributing, since the authors that are contributing are people who actually like lived through these actual case studies, because we write them based off of experience, there's just something different to them than a lot of the other case study books out there. So that's why I love that one. Okay. Not a single person has put an introduction in the chat. You guys have to be lively for the people because there's like 100 people who registered for this class, and I know most of them are going to go for the recorded, so we have to be a little lively for them when they're watching it. All right, so let's start reading this case study. Their chief complaint is low platelets. So we have a new patient presenting to us, age 42, and they're referred by his health insurance helpline to establish care and to discuss low platelets. Noticed on a recent life insurance blood test. And this is common, so someone will come in for screening or for life insurance or something like that, and you have to do a slew of tests just to see, like, if you're even for health insurance. So that was a very common thing that I've done in the past is assessing someone who is trying to get a discount on their health insurance premiums. And so you do a full assessment. You get a couple of metrics and some labs. So this gentleman here was going to apply for life insurance. So he has been without a PCP since college, and this is not uncommon for males. So sometimes the last time a male has been to a doctor is like 17, 18 before they went to college. Sometimes they might get a little care during college, but They usually will go without a provider, occasionally show up in an urgent care clinic for some sort of an infection or injury. And then they hit their 40s and they start to have some signs of chronic disease or something like this. So he has been without a PCP since college and has no prior labs for comparison. So we have no idea how long this has been going on, and we have no baseline to compare it to. He feels completely well, stating he rarely gets sick, using the local urgent care center, rarely for colds and minor injuries. I've never read this case study, but that's exactly what I said. He denies any unusual bleeding, bruising, or skin changes. There is no known personal or family history of blood or liver disorders. So then we go into our review of systems. That's next. Review of systems is all of those subjective things. This is the things that the patient tells us. So that's a review of systems. So start thinking in your head, what are some questions that you would want to ask him? So these are things that you can't necessarily assess. The patient has to tell you. So if someone has liver problems, what are some things that you would want to ask about? And if you want to throw on your mic at this point and toss out a thing or two, what's something you would want to ask the patient? If we don't have anything from the crowd, we've got something in the chat. Wonderful. Any drug or alcohol use? Yes. Yes, that's absolutely a good question for the review of systems. So let's look at this. The review of systems is negative for fever, chills, weight loss, or fatigue. He has no nasal congestion, earache, or sore throat, no changes in vision, tearing or redness or yellowing of the eyes, no cough, shortness of breath, or wheezing, no chest pain, palpitations, or edema, no abdominal pain, nausea, vomiting, reflux, melena, change in bowel symptoms, bowel movements, or rectal bleeding, no rashes, jaundice, pruritus, or skin lesions, no bruising, epistaxis, or swollen lymph nodes, and then neuro, no headache, dizziness, weakness, or paresthesia, and psych, no insomnia, depression, or anxiety. What's the relevant history? So the patient underwent an appendectomy as a child but has no other hospitalizations or medical diagnoses. He denies taking any prescription or OTC meds, herbs, vitamins, or other supplements, because that's important too, because somebody could be dealing with, a back problem and have been just chronically taking Tylenol over and over again and, been causing some liver damage and just not knowing that what they were doing was, hurting them. He had his childhood vaccines and receives an annual flu shot from an urgent care clinic. His family history is significant for diabetes. He is married and has 2 young children. He is the director of sales for a local winery, working 50 hours per week, and has worked there for 17 years. He drinks 3 to 4 glasses of wine daily, which he describes as a necessary part of his job. He has never had any work, home, or legal problems related to alcohol. He denies binges, cravings, or withdrawals. No tobacco or recreational drugs. He eats out 4 days per week. Steak, potatoes, pasta, and bread. Wife cooks well at home, including carne asada with tortillas, rice, and beans. Oh, we have so many starches and carbs. His exercise is limited to taking his kids to a park once a week. No meds, no allergies. Temp's fine. Heart rate's fine. Respiration's fine. Blood pressure is slightly elevated. Oxygen is fine. And let's see, what's his BMI is 35. With the diet, I was kind of expecting something like that with a BMI of 35. Well-developed, over-nourished Latino, alert-oriented ×4, all vital signs stable and no acute distress, pleasant affect, euthymic mood, meaning, just, again, kind of along with that pleasant affect, fluent speech, good insight, skin, hair, and nails. So this is something you're going to want to think of here is what type of findings do you think you would find on an examination? So what are some things, you can mic or you can put in chat, what are some things that you would think of on skin, hair, and nails? And then what's another major system that we are going to assess deeply? Obviously, we're going to do a lot of GI assessment here. What are some things that we might see on the GI assessment? And what are some things we might see on skin, hair, and nails? For the skin, hair, and nails, we have skin warm and dry, moderate palmar erythema present bilaterally, and two small spider angiomas of anterior chest. That would be an expected finding, but no jaundice, rashes, or varicosities, no abnormal findings with the hair and nail exam. Eyes look good. Again, we have conjunctiva clear because, again, we would want to be looking for yellowing. ENT mouth, no oropharyngeal lesions, no lymphadenopathy, no thyromegaly, no gynecomastia, or axillary lymphadenopathy, Heart looks good, regular rate and rhythm, carotid and radial pulses are 2+. Lungs are clear to auscultation, and then abdomen. And this is again where we might find some positive findings here as well. So he's protuberant with central adiposity. So he remember he is overweight. He has BMI of 35, and so central adiposity would not be unsurprising. But we have to determine whether or not that is, how does it feel? What is the texture, so to speak, of the abdomen? Are we tight and taut, or is it more of an adiposity? Well-healed surgical scar at the right lower quadrant, no caput medusa, bulging flanks, or fluid wave present. So that fluid wave, again, we're testing for ascites. Normal active bowel sounds noted in all quadrants, no bruits or friction rubs, normal areas of tympany and dullness to percussion noted, meaning over organs, we're hearing dullness, over the stomach, we're hearing tympany. It is soft and non-tender with no masses or hernia. He does have a hepatomegaly with a liver span percussing to the 20 centimeters at the midclavicular line. Palpated liver edges is firm but smooth and non-tender. Spleen tip is palpable but non-tender. And then MSK, trace pitting edema of the bilateral pretibial areas. Other than that, no findings. Neurologic is normal. And here are our labs. So go ahead and take a look at these labs. I'm going to leave this here for just a moment for you to look at. Kind of go down through those labs and start thinking about what you're finding. There's those low platelets. Doing a smear. Normal morphology of the platelets, but low platelets. Let's look out where else are some things. That's not that's not terribly high. Albumin, however, is low. I'm going through here. Seeing that one is high. A1C, it again, just barely high. He is borderline diabetic, like pre-diabetic. And then there's, let's see, there we go. There's something there. We got negative, positive, negative, negative. So what's that? What's that finding indicate to us? Keep that one in mind. Good. Good. If you look in the chat, we have a good answer there. I'm not going to spoil it yet because I want you to think about that one. Because if you pair it with this, it gives you the answer. If you want to check the chat, there's the answer. Total cholesterol, little elevated. HDL is barely low. LDL is elevated. Triglycerides elevated. Okay? All right, so this is one of my favorite parts. This is where I learned so much from this because it's going to give you all the differentials that you could consider, and it's going to tell you which features of the assessment, history, and ROS either say, yes, it's more likely this, or because of this, we could probably rule out this diagnosis. They do put them in no specific order in order for us to kind of work it out ourselves instead of just giving it away straight away. Differential diagnosis. And do one thing I want to go back is when the recording comes out, it will not give us that, you won't be able to really see the chat. So I did want to go ahead and say this out loud. This means this patient is vaccinated because they have the surface antigen, but not the core. Meaning they've had the vaccine, but they do not have actually Hep B. Okay. So what's our differentials? Alcohol-associated liver disease is a result of chronic heavy alcohol intake that can cause a fatty liver and can lower platelets even in the absence of cirrhosis. In patients with chronic liver disease and elevated transaminases, when AST is greater than ALT, cirrhosis should be suspected. But when the AST to ALT ratio is greater than 2, alcohol-associated hepatitis should be suspected. This patient here has a flipped ratio of AST is greater than ALT, but the ratio is less than 2. Though alcohol-associated liver disease is likely based on his alcohol intake, other lab and physical findings suggest the presence of a more specific diagnosis rather than alcohol effects alone. So again, for those of you who just maybe popped in, here's the patient's AST, ALT. So you write that down. ALT is 28, AST is 40. So we're going down here. The AST is greater than the ALT, but it is not, the ratio is still less than 2, okay? Hepatic cirrhosis is a suspected diagnosis when a patient has low platelets, low albumin, and elevated direct bilirubin. So let's go back and look up here and see what we had. We have low platelets, low albumin, and high direct bilirubin. Okay. A firm liver, splenomegaly, because remember we could palpate the tip. You normally can't feel a spleen. Pitting edema, he had that pre-tibular pitting edema, palmar erythema, and vascular spiders. He had those spider exams, or spider vein kind of things on the angiomas on exam are strongly suggestive of cirrhosis. Is that the right word? Let me make sure I got that. Yeah, spider angiomas. He had the 2 spider angiomas. Okay. And that these findings are strongly suggestive of cirrhosis. So again, he had most of those symptoms. He has the correct labs. He has a firm liver. He has pitting edema, splenomegaly, palmar erythema, and vascular spider angiomas. Okay, so that's highly suggestive of cirrhosis. So when we're looking at alcohol-associated liver disease versus the hepatic cirrhosis is more likely. But let's look at the other 4 possible diagnoses as well and kind of rule them in or out. Immune thrombocytopenia is more common in females and may be associated with chronic infection like HIV, H. pylori or HCV, or an autoimmune disease such as SLE or thyroid disease. As there are no specific confirmatory tests, it is a diagnosis of exclusion after ruling out other causes. So with this patient, he doesn't fit a lot of those risk factors. We have male. He does not have any indications of HIV or Hep C or thyroid disease. He had no thyromegaly. And since we have other diagnoses we need to work with first, we would not immediately diagnose somebody with this. Rule out everything else first. Our next one is thrombotic thrombocytopenic purpura, which is a rare disorder. It's also a medical emergency, can cause renal failure and stroke, among other complications. It is unlikely in this patient because he does not have anemia or physical findings such as fever. Obviously, purpura, petechia, pallor, or jaundice. This one, lymphoproliferative disorders, acute leukemia or non-Hodgkin's lymphoma or myelodysplastic syndrome is also a less likely diagnosis. They do have the splenomegaly, which is associated with lymphoproliferative disorders. This patient has a normal white blood count and peripheral smear, no fevers, no weight loss, and no lymphadenopathy on exam. So nothing going on there with the lymph system when we were going through our assessment. Medication related is also unlikely here because he's not taking any medications, nothing over the counter, nothing illegal. So the only intake we're concerned with him about is those 4 glasses of wine per day. Heparin is well known to induce thrombocytopenia. Herbal and vitamin supplements, as well as prescription and non-prescription medications can. And here is something you might want to write down. Here's some of the medications that could cause low platelets: penicillin, sulfonamides, NSAIDs, furosemide, ranitidine, quinine, and immune suppressants. Again, this diagnosis is obviously unlikely unless he's just plain lying to us because he doesn't take anything. He's been healthy. All right, so now seeing all of these diagnoses kind of laid out, what would be your most likely diagnosis? Again, you can put on your mic or you can put in the chat. What do you think we're dealing with this patient? And what would your next step be? Do you need to do any further diagnostics? Do you need to order any radiologic exams, ultrasound? Is there anything that you want to order? What's our diagnosis? And then what do you want to order? Excellent. So we've got one vote for hepatic cirrhosis and to order a FibroScan. Okay. Anyone else want to put in a piece here? Okay, our most likely a liver ultrasound from, okay, yes, good. The most likely diagnosis for this patient is cirrhosis, likely due to a combination of non-alcoholic fatty liver disease and alcohol-associated liver disease. So his diet combined with his alcohol intake has created this cirrhosis. Okay, so many chronic liver diseases cause cirrhosis, including viral hepatitis, alcoholic, now called alcohol-associated liver disease, and non-alcoholic fatty liver disease that includes NASH. The most common cause of chronic liver disease in the United States is the non-alcoholic fatty liver disease. This is definitely becoming more and more prevalent, so I'm glad that we're going to get to talk about it. Today, men have twice the risk compared to women, and there's a higher prevalence in Hispanic compared to Caucasian and African ethnicities. This patient screens negative for Hep B and Hep C. His family has a history of diabetes. He has central obesity, meaning abdominal adiposity, atherogenic dyslipidemia, elevated glucose A1C, just barely, but enough to take note of, and diet sedentarism are risk factors for NAFLD. His long-standing heavy alcohol intake is a risk factor for alcohol-associated fatty liver. And in the absence of other chronic liver diseases, cirrhosis due to both is the most likely diagnosis. So he was hit with kind of a double whammy because alcohol and diet kind of hit him, and he was Hispanic and diabetes. So perfect storm for him. Definitely has, if you see all of this here, we're definitely looking at those conditions where there's just, all of the endocrine kind of things at play here with him, all of that at once. So demonstrate your understanding about the pathophys. There's a lot here. It goes really deep. Okay, this section goes really deep. So if you're in your pathophys class, this can be helpful. I will say that a lot of this stuff in this section isn't going to be on like your board exams as far as pathophys. So if you're in your early classes, you're in your 3Ps, keep working through the pathophys class, knowing that a deeper understanding is important to help you understand what's coming later in your classes, to put 2 and 2 together and to kind of understand how different diseases kind of interact with each other. So NAFLD is the hepatic manifestation of insulin resistance. So it's kind of like diabetes of the liver. Okay, so it is related to the insulin resistance. NAFLD develops in patients with a genetic predisposition for metabolic syndrome. That's the word I was trying to come up with earlier. So this patient definitely is dealing with metabolic syndrome because he's got the lipids, he's got elevated fasting glucose. He has definitely got a state of overnutrition combined with postprandial hyperglycemia, which is resulting in hepatocyte uptake and storage of lipids, causing the hepatomegaly. Approximately 90% of patients with NAFLD have simple steatosis, while 10% go on to develop NASH, which is a precursor to cirrhosis and hepatocellular carcinoma. So people with this condition are at risk for developing cancer. In NASH, specific subtypes of lipids, such as saturated free fatty acids, are hepatotoxic, causing mitochondrial injury, necrosis, and apoptosis. Hepatocyte death evidenced by serum transaminase elevation, particularly in elevated ALT, stimulates the immune system to release inflammatory cytokines, which hits the liver, that activates hepatic stellate cells to mobilize and secrete collagen, forming scar tissue. So now we have that hardening that happens of the liver. So it's all this process. It's a response to the cell death that's occurring, and you're creating scarring, and you're scarring it down. And then you're just going to have tissue that can't recover, that isn't going to do what it's supposed to do. The underlying pro-inflammatory state of insulin resistance and additional oxidative stress is the second hit to the liver. And this cycle of hepatocellular inflammation and scarring, with gradual loss of the liver parenchyma, the tissue itself, eventually progresses to liver failure. And anytime we have changes in cellular tissue, that is why there's risk of cancer, because we're having changes to the cells themselves. So when you think about the most easy one to really think of is tanning is changing the cells, and the more we're tanning, we're changing the cells to where it can create cancer, right? So that's kind of like the easiest way to think about, okay, when something is injuring and changing a cell repeatedly, it is what puts us at risk for cancer. In ESLD, transaminases normalize owing to the loss of normal hepatocytes. When additional hepatotoxins or oxidative stressors are present, and this guy, he's drinking quite a bit, such as alcohol, smoking, any viral hepatitis, hereditary liver disease, such as an A1 antitrypsin deficiency, or hepatotoxic medications like Tylenol, the progression to ESLD is accelerated. So his pathway went faster. He's only 42. The pathogenesis of alcoholic liver disease occurs along a similar fatty acid synthesis, inflammation, necrosis, fibrosis, along a spectrum of alcoholic steatosis, alcoholic hepatitis, and alcoholic cirrhosis. So then understanding all of that, we understand what can happen to this patient if he's not treated properly because we understand what's happening at a cellular level. Now, at a practical level, what kind of tests are we ordering? So we're going to get some more labs. We're going to get a serum ferritin, ANA, A1AT, that's the A1 antitrypsin, a ceruloplasmin to screen for Wilson disease, PT and INR to assess liver synthetic function, HAV-AB total to determine whether vaccination is required, or and a urinalysis to assess basic kidney and bladder functions. What kind of imaging do we want? We want to get the abdominal ultrasound. A lot of the stomach, the GI area, we're going to be using ultrasound to look at, ultrasound or CT. For this person, we're wanting to assess an organ, so we're going to use an abdominal ultrasound, which is good to look at the spleen, the gallbladder, the liver, all of those organs. So what are the results? The previously mentioned labs and imaging were not significant, except moderately elevated ferritin, which is common in patients with insulin resistance due to dysmetabolic iron overload. The patient had immunity against Hep A and therefore does not need a vaccine. Okay, so that's something that we want to consider because we don't want to have any further insults. Remember how it talks about the confounding factors when we're under the pathophys. The more problems we have, the more confounding factors that we have, the faster we're accelerating end-stage liver disease. So we want to make sure he's vaccinated against anything we can vaccinate for to prevent his liver from taking any further injuries. So Hep A vaccine, but he was already resistant. Gastroenterology, transient elastography was done to confirm the diagnosis of cirrhosis. And so he was sent to GI. That is our step. Remember, what is the point of a family nurse practitioner? Is to be an appropriate gatekeeper for other resources. We are to manage the things that we can manage within house, and then we are to appropriately order diagnostics and refer out. One of the most, a lot of these studies have been coming out lately about, okay, so yes, nurse practitioners, patients like them. They seem to be doing well as far as outcomes and management of things like diabetes and hypertension. But some of the big issues that we're facing right now as a career or as a whole is over-referring and over-ordering, which means we're no longer being as cost-effective as original studies were showing. Because if we're using up resources that could be allocated appropriately elsewhere, then it's harmful to the system as a whole. So that's one thing that we want to make sure that we're doing is being appropriate gatekeepers of our resources as family and primary care nurse practitioners. So this is obviously a patient that we want to refer to GI, but we need to have made sure that these labs have been done before we're sending him out because we need to address everything that we can address in-house and to have everything prepared for the GI to look at when they get there. Okay. Demonstrate your understanding of the prevalence, screening for early intervention, and prognosis associated with the condition. So again, in the book, if you buy the physical book, it's like a workbook where you can actually just like fill in and then you go online and check it out on the computer. You can look at your answers, or you can just do it straight from the computer and just kind of click down. So prevalence, early intervention, and prognosis. AUD is a prevalent condition affecting approximately 15 million people in the United States. AUD is associated with multiple morbidities and significant early mortality, with the average life expectancy decreased by up to 28 years. Lifetime prevalence of AUD is 29%, and less than 20% of patients are ever treated. Alcohol-associated liver disease and Hep C are the primary indication for liver transplant in the United States. The American Association for the Study of Liver Disease guidelines states that all primary care patients, gastroenterology and hepatology patients should be screened for alcohol use. Intervention and referral to treatment are recommended for patients suspected of AUD. Abstinence should be recommended. So this patient, he really cannot continue to consume alcohol, or else he is just going to keep adding insult and injury to this liver. Even though it's part of his job, it's part of his culture, because daily he drinks alcohol because he works at a winery, okay? But he can no longer do this. Let's see. Oh, Audit C is a good screening tool. Prognosis, though advanced cirrhosis is progressive and eventually fatal disease, patients with early compensated cirrhosis typically live for years with few symptoms. Remember, he is not fairly symptomatic. This was found on accident while he was applying for life insurance. Okay. There's evidence that early fibrosis may be reversible when contributing factors such as insulin resistance and alcohol, as with this patient, are mitigated. Once hepatic decompensation occurs, which would be evidenced by these findings, okay, jaundice, ascites, didn't have either of those. He was not yellowed. He did not have ascites. Variceal bleeding, no encephalopathy, no hepatorenal syndrome, no hepatocellular carcinoma. That is when transplant referral is indicated at that point. 1 year post-transplant survival rates are 85 to 90%. 5-year rates are between 70 and 80%. Okay. Hepatocellular carcinoma as a result of NASH cirrhosis is now the fastest growing indication for liver transplant in the United States. The next section is very brief. We won't read through it. These are all the ICD-10 codes and CPT codes that you would want to use. Just good practice. What is appropriate patient education? Very brief. Again, we're sending this patient out to GI. He does need that he is pre-diabetic and insulin resistant. He does need to follow a diabetic diet. He is eating so many carbs. We've got to drop the carbs down. Cannot drink any further, and really needs to ask about anything. He needs to ask about anything that he is going to put in his mouth, supplements, vitamins, things like that, because we do not want to, again, aggravate that liver when it's in such a fragile state. We are at a place where, again, we can mitigate like long-term fibrosis, possibly even reverse. So we want to be very careful with what we do right now. Skip that section, and then we'll skip those two as well. Those are thought questions that you can work on with yourself. But here's my favorite part, because again, these are actual case studies from actual patients and actual providers with enough information changed up, obviously, to HIPAA. This patient was highly motivated to follow all recommendations, and the additional diagnostic tests I ordered returned normal aside from a moderately elevated ferritin, which is common in patients with the insulin resistance due to dysmetabolic iron overload. He stopped drinking immediately, started exercising, saw a dietitian, and lost 30 pounds in 3 months. His labs improved with normalization of the direct bilirubin, albumin, triglycerides, glucose, and ferritin. His platelet count increased to 130. He saw a gastroenterologist as referred, who confirmed diagnosis. They also did an endoscopic screening for esophageal varices. And it was and continues to be negative. That is one thing that we want to look for, is esophageal varices. So that's why it's important to ask, are they coughing up any blood? That's a screening question you want to ask for on your liver patients, because you're looking for esophageal varices. I considered referring him to a psychologist for the substance use, but it was not necessary as he stopped drinking on his own. I think for this patient, because it wasn't like a going home drinking coping mechanism, it was, I work at a winery and I casually drink 3 to 4 glasses of wine while walking around with my customers all day. It was probably easier for him to quit. It was a different kind of attachment to alcohol. So that's when looking at the patient as an individual, instead of just labeling him, you looked at him as a person. I wouldn't necessarily even call this guy an alcoholic. He didn't understand what the alcohol was doing to him. All right, so you did not send him to a psychiatrist. 8 years later, his weight, liver function, platelets, and lipids remain stable. His A1C remains less than 6.0. He continues to have screenings for varices and hepatocellular carcinoma, and they are still negative, and he continues to be asymptomatic with well-compensated cirrhosis and no need for a transplant referral. Let's go down here to insight from the PCP. This person here has worked both in GI and family med. So working in both GI and family med, I have treated many patients with liver disease who were heavy alcohol users. This is the first and only heavy drinker I've cared for who stopped all alcohol completely the moment I advised him to do so. He obviously didn't have an unhealthy relationship with alcohol. That's why it is so important, again, to look at the patient as an individual. The patient's occupation as a wine salesman played a significant role in the rapid progression of his underlying non-alcoholic fatty liver. Adding alcohol to any chronic liver disease accelerates the development of fibrosis, and discontinuing alcohol plus treating his insulin resistance normalized liver function despite his advanced fibrosis. The patient explained that he was never a drinker before this position and didn't really enjoy it, but that he was compelled to drink the wines he sold with his customers. He was angry at himself for allowing his high alcohol tolerance, free access to wine, and lack of knowledge about health effects to cause such a serious health problem. I'm not an alcoholic. How can I have cirrhosis? It is impossible to know how much of his cirrhosis was due to NAFLD, NASH, versus how much was due to the alcohol. But I do know that with continued support from his care team, coupled with high motivation to be healthy, this patient will continue to do very well. We do have a question in the comments that says, could we start him on a low-intensity statin? Statins are kind of tough on the liver, so I wouldn't start a statin in this patient. Also, I would want to try conservative measures first, including diet and exercise, which the patient was able to do successfully. He went ahead and made remarkable changes, losing 30 pounds within that first 3 months. So definitely a great outcome. It's not always this easy with our patients, of course, but here's a good example of not rushing to judgment, but looking at all of the different factors of somebody that's kind of put him in a tough spot that he didn't anticipate. So polite education works well for this guy. All right, any questions on this one so far? Any other questions or thoughts? Again, feel free to put on your mic or just listen in. Okay, we are going to go to another one here. Speaking of shortness of breath, I'm going to take a few deep breaths. I talk fast. All right, shortness of breath in a geriatric male. So when you see your chief complaint and you see shortness of breath, or you see fatigue, or you see dizziness, you know it's one of those ones where being the detective is going to help you find out what's the root source of this vague symptom. Because that is it. You've either got, okay, it's obviously an ear infection. They have ear pain. I look in there, see a red erythematous bulging tympanic membrane. Awesome. Piece 1, piece 2, solved puzzle. But when it's a vague symptom, you have to play a lot more of detective, and you don't just want to throw a battery of labs at them just because you can. You want to be judicious in what you select in order to not tax the patient financially. All right. Even insured patients, we don't want to tax the system. All right, a 74-year-old man presents for shortness of breath, cough, wheezing, and fatigue for 1 week. Okay, so we wouldn't call this chronic. Okay. His shortness of breath and cough have worsened in the past 3 days, which prompted him to seek care. He denies fever, sweating, or chills. He has been getting winded when he walks to his mailbox. On further questioning, the patient admits to smoking 1 pack of cigarettes a day for the past 50 years and has no desire to quit. I will die soon anyway, why quit now? On further review of his chart, it is noted that he has presented with the same chief complaint in the past and was diagnosed with acute bronchitis and treated with albuterol and antibiotics, and he has not been to the office in over 3 years. Okay, so we have some interesting timing things here. When you have someone show up with a respiratory condition, you do want to look and see if there's any patterning, because when we're thinking about respiratory, we're thinking about, is this an acute infection, or is this the first signs of a chronic disease? Is this an exacerbation of a chronic disease? Is this any kind of showing an underlying issue with an organ? Why are we having all of these symptoms? Do we have a cold, bronchitis, pneumonia, or are we looking at CHF, COPD, emphysema? Which way are we going with this? This guy doesn't have a fever. He has a smoking history. So you're already starting to form your pathway, but let's get some more information. His review of systems has a productive cough, wheezing, shortness of breath, fatigue, dyspnea on exertion, crackles, clubbing of his fingernails. His review of systems is negative for fever, chills, adenopathy, cyanosis, pallor, palpitations, or barrel chest. What is his relevant history? He has medically uncontrolled hypertension and hyperlipidemia. He has been using albuterol and beclomethasone. Occasionally for a shortness of breath, doesn't know why he takes them. Again, he hasn't been here in 3 years. We're probably looking at someone who's let all of his medications drop, maybe has been to an urgent care clinic and got a couple refills here and there for something, or is using expired inhalers. He denies having a history of asthma, is a smoker, no flu vaccine, not sure if he's ever had pneumovax, drinks about 6 12-ounce beers 3 times a week. I guess the theme of tonight is going to be alcohol. He is not sure if he has, he is retired but used to work as an auto mechanic. No surgical history, doesn't know his family history. No allergies. These are the medications he's probably supposed to be taking. It says he's having, he has medically uncontrolled hypertension and hyperlipidemia. So maybe he's just been getting like phoning in and getting refills. I don't know how he's been getting refills. He hasn't been in 3 years. Lisinopril, atorvastatin, albuterol, beclomethasone, ibuprofen, and guaifenesin. Let's look at his vitals. Again, no fever. That's fine. That's okay. That's elevated. That's barely okay, but okay enough. And his, let's see, BMI is 26.1. Appears to be in mild respiratory distress due to accessory muscle usage for breathing, but not tripoding. Noted a thin body habitus. So we've got a thin fellow here who's not tripoding, but is definitely using his accessory muscles. So, you know, we're breathing here, but you'll see them working. It's in here. They're using the muscles down the side or up here. And they're working hard to get that deep breath all the way down in. As registered nurses who've worked in floors for years, we do have the benefit, this is something that I call a transferable skill, of knowing what a patient in an exacerbation of a chronic disease looks like. That's definitely something that we're going to be able to identify routinely. Normal affect and judgment, mild clubbing, no pallor or cyanosis, pink and moist oropharyngeal mucosa, no adenopathy. Definitely going to key in on those lungs. Diffuse wheezing and crackles noted in both upper and lower lung fields. Labored breathing with accessory muscle usage noted. Symmetrical expansion noted. He does have increased resonance to percussion. What does that mean? What does increased resonance to percussion mean? What does that finding indicate? If we have increased resonance, so think about that. It's increased sound, increased resonance. With consolidation, we would find dullness or a decrease. With hyperinflation, we would have that increased resonance. So he has decreased breath sounds throughout, however, and he has regular rate and rhythm of the heart. Neuro looks good. So what is our differential diagnoses here? Throw out a few for me here. Throw out a few differentials. What do you think is going to be on the list that we need to consider? Correct, yes. What are other things we might want to consider? Yeah, good. So let's look at each of these diagnoses and why or why not they would be it. And these are definitely all the ones we want to think about here with this patient, and even a couple that we didn't think of. So asthma, he doesn't sound very asthmatic to us, right? So asthma is a chronic inflammatory, and again, just to mention for anybody who kind of hopped in later, these are not listed in any specific order as from most likely to least likely. They're just all mixed up, okay? So asthma is a chronic inflammatory airway disease that can cause intermittent airway obstruction, but is reversible with treatment. Symptoms include wheezing, chest tightness, cough, and shortness of breath. Because he has inhalers, and we don't know why, asthma should be on the differential list. However, he's got a smoking history, decreased breath sounds. We're going to highly consider something else. So probably not asthma. Acute bronchitis is a self-limiting lung infection, usually caused by viral etiology, but it can be bacterial. The condition can last for a few weeks. The cough can definitely linger. Acute bronchitis can cause lung inflammation that may result in cough, wheezing, and sputum production. And to me, that's one of the hardest things as a new graduate to kind of look at bronchitis versus pneumonia, because bronchitis does often create a productive cough through this inflammation pathway. So we'll talk a little bit about pneumonia on the next line about why it's a little bit different. Given this patient's H&P, this is not a likely diagnosis because we've had previous, he could have had bronchitis more than once. But given his history, the fact that somebody's put him on inhalers at some point, he just doesn't know why, we would want to consider something else. So pneumonia can be bacterial, fungal, or viral, causes systemic symptoms of fever and malaise. So that's something you don't really see with bronchitis. You don't necessarily see the fever and the I'm so tired, I can't get out of bed fatigue that comes with pneumonia. Along with wheezing, rales, bronchi, chest pain, and shortness of breath. However, he's afebrile, which is very, very uncommon with pneumonia. It's not unheard of. I could be a perfect case study for that. I have definitely had lung trouble most of my life. I've had asthma. I've had 3 bouts of pneumonia, one of which has led to hospitalization. And I don't create a fever when I have these pneumonias. Like, pull me up on a CT scan, 3 lobes full of junk, no fever. So it's not impossible, but it is very uncommon. COPD is a likely diagnosis for this patient. He has a 50-year smoking history and presents with cough, shortness of breath, decreased breath sounds. While this is a likely diagnosis, he does still have something that is acute going on with him. CHF patients usually have a history of left side diastolic heart failure. They present with shortness of breath, crackles, edema, and weight gain. It's reasonable to consider this. His presentation does suggest something acute is happening at this time, and we don't really see the edema or the rapid weight gain. And again, we don't have great data as far as weight to determine that, but he doesn't have edema. ACE inhibitor-induced cough, we should consider this because he is on an ACE, and at any time while someone is taking an ACE, they can develop the ACE inhibitor-induced cough. It doesn't have to be on the first day or the first week. It can be years in that they develop the cough, but the cough has key features. It's not related to any other kind of infectious symptoms. Obviously not going to have a fever. It's not productive. It is dry. It's persistent. Nothing relieves it. It's constant. It's a trickle-like cough. It usually starts right after starting the medication, but in some cases can start a few weeks later. And I worked in outpatient cardiology while I was in grad school, and there were absolutely patients who it would start years later. They would take them off of it, and the cough would absolutely go away. But most of the time, it's when they start taking it. It doesn't have to be. There's always caveats to everything that we're saying. COPD with acute exacerbation, but I mean, you hear hooves, you think a horse. There is going to be unicorns from time to time. So COPD with acute exacerbation, this is, the one we're probably thinking, right? COPD with an acute exacerbation. He's got worsening symptoms. He's had a remarkable change within the last week, and especially within the last 3 days. That is what led him to even come into the clinic. So it's either severity or frequency. This patient has experienced symptoms in the past, is already taking inhalers. He does have a reduced oxygen saturation. It's 93, which is super borderline. Also, his long-term smoking history supports this diagnosis as well. So again, what's our most likely diagnosis? I think we've already beaten that one up plenty. COPD with an acute exacerbation. He's likely had it for some time. Obviously doesn't understand his diagnosis because he wasn't able to articulate it. Someone has clearly diagnosed him with this before. It's just gotten dropped somehow. Okay. We already had a lot of fun doing the pathophys for our first one today, so we won't wear that out completely to do 2 whole sets of pathophys today. Let's see, what tests or imaging studies would be ordered? Which ones, why? Is there anything that can be done in the clinic? Is there anything that we need to send them out for? Go ahead and put that in the chat or say it out loud. What are we going to order? Appropriately order, don't under order. That's our goal. Don't miss something. Such a fine balance in that first year. Give yourself lots of grace the first year and then start building those pathways. Okay. What kind of things can we do? We're going to do point of care testing. This clinic has a chest x-ray available, so they went ahead and did a chest x-ray. Because there was no recent one on his chart, we do need one to kind of look at the shape. What kind of shapes would you expect on a COPD? What kind of terms would you use to describe an x-ray of a COPD patient? Hyperinflation and a flattened diaphragm. Hyperinflation, flattened diaphragm for sure. Yep. CBC to rule out anemia. Anemia of chronic disease would be a possibility here. BNP and echocardiogram for left-sided heart failure suspicion. Chronic people have diseases hiding under other diseases, right? So when we're having someone who has had unhealthy behaviors, geriatric, hasn't had a lot of close follow-up care, has a couple of diagnoses on his chart, chronic diseases hide under other chronic diseases. CMP to screen electrolytes, kidney function, and liver function, ABGs to rule out compensated or uncompensated metabolic acidosis. Those were considered but not done for this patient. Well, those are things that we want to think about. We usually want to do conservative measures first. So doing the chest x-ray absolutely needs to be done. If we were to kind of not see improvements with the new treatment we will set up for this patient, coming back and doing some of these things can be helpful. Also, a lot of these things can be deferred for a follow-up visit if we want to talk about, let's look at your other conditions that are going on with you. But right now we need to stare down the dragon in the room. Remember, we're having short visits and we need to address the dragon, the thing that's going to hurt the patient the quickest, and say, hey, and also I need you to come back in X number of days or weeks so that we can look at some of these other things and see, we definitely need to get a CBC and BNP on this guy. Like, that would be ideal. Okay, so we can check out what these other conditions are doing and to eventually assess to see if there is heart failure. But those things can be put on the back burner. All would be appropriate, probably not today. A pulmonary function test can be done with a pulmonologist. Confirmation of the diagnosis is typically made by an FEV1 FVC ratio of 0.7 or less, and the symptoms of cough and shortness of breath are reversible after using bronchodilators. And that's a really quick test that anybody can do. A lot of clinics obviously keep a nebulizer on site, mask, and just nebulizes some albuterol for the patient. And seeing reversal of the symptoms is helpful for asthma and COPD. What are the next steps? Nebulizer. Given a nebulized treatment with albuterol and ipratropium, what does that ipratropium do? What's the benefit of that ipratropium? The albuterol is going to open up. What's that ipratropium going to do? It's going to address the inflammation and the exudate. It's going to dry them up. Okay. What else are we going to do for this patient? Oh, good. Oxygen saturation improved to 95%. It just bumped up 2 points, but that is a positive improvement. So we're happy with seeing those improvements in his symptoms. And then patients who are on a COPD, who are having a COPD exacerbation, do benefit from antibiotics. There is a decreased mortality and risk of adverse outcomes when patients are put on antibiotics during a COPD exacerbation. And while as much as we say don't prescribe azithromycin, this one's actually fairly appropriate for a COPD exacerbation. It's nicely broad spectrum, which we like. We like the broad spectrum here because it's going to address your gram positives, your gram negatives, your atypicals. And so it's going to have all that coverage, H influenza, and everything. And then 5-day course of oral prednisone, 60 milligrams once a day for 5 days. Don't you guys dare taper anything unless you go past 10 days. It is insane the number of tapers that I see NPs prescribed. And it is like, I read Doctor, which is the like Reddit for against independent practice for APPs. But I read it just to learn what they think. Like, what are they seeing that we're doing that's so wrong that makes them hate us so much? And this is, of course, not all physicians. Many of them are very respectful. Many of them just have some concerns, and some of them are valid. And so one of the major concerns is the ridiculous number of tapers that NPs prescribe. Stop tapering things, okay? You can do up to 10 days, full dose, and then drop it. If you're wanting to have like a really, really long-term treatment plan with prednisone involved, you might want to consult somebody if you need to have them on, prednisone that long. Most things that we're seeing as primary care providers can be handled with just a course of antibiotics or a course of prednisone with no taper, which is also, of course, going to increase the compliance of the patient. I've been put on tapers before. They're impossible to follow. So just prescribe them a burst and then end it. His prescription for inhaled albuterol and beclomethasone was refilled. They added tiotropium. Patient also received a prescription for continuous nasal home oxygen and a referral to a pulmonologist. He received emergency precautions and was advised to return in 5 to 7 days for a recheck. Let's get that. There's your ICD-10 codes if you're super curious. What kind of education are we going to talk about? He's probably not going to stop smoking. He's already got in his head that he's older. He wants to enjoy his cigarettes. He's 74. What's the point of quitting? We can talk about it. We can also encourage influenza and the pneumovax for this patient. I think that would definitely be prudent and helpful for him. Because if he is going to continue to smoke, let's not also throw infection after infection on top of it. Okay. So, outcome and insight from the PCP. The patient was treated for an acute exacerbation of COPD and started on albuterol, beclomethasone, and tiotropium. He was given a pneumococcal and influenza vaccine. Good. His hypertension and hyperlipidemia medications were resumed. He followed up on day 5 and was pleased to inform he was back to baseline and was going to see his pulmonologist. Not ready to quit, but will consider quitting, needs time to think. During his follow-up, his other diagnoses were discussed and routine blood work was ordered. See, it's more appropriate to kind of split it up here. Okay, we've got him back in. We're just going to recheck his lungs, see if his symptoms have improved, and start addressing some other things that are going on with him, and hopefully get him back into routine healthcare. Maybe encourage him to stop popping in every 3 to 5 years with much worse chronic conditions. So, because this was my first meeting with this patient, I took time to review his chart, look at past visit summaries to gain insight. It seems he only came to the clinic when he was sick with similar symptoms of cough, shortness of breath, and worsening sputum production. He was non-compliant with his follow-ups for other problems. Took some time to have a frank discussion regarding his medical history and health status and explain my suspicion of COPD. Shared some medical facts about the disease process with him and expressed my concern about his prognosis. He stated that when he came into the clinic in the past, he was told he had bronchitis. And this is something that happens. It's not even necessarily like a misdiagnosis when you're like consistently diagnosing the patient with bronchitis. But once you see a pattern where you see bronchitis coming in over and over again, we're either missing an asthma diagnosis or a COPD diagnosis. Again, not always, but you really want to consider that as if you're having repeated bronchitis, you might want to look and see if it's more of an asthma or a COPD. So again, in the past, he was just always told he had bronchitis, was sent home with antibiotics and inhalers. And again, we really shouldn't be sending home patients with bronchitis alone with inhalers. So that probably, the providers who were seeing him probably understood what was going on, but weren't taking the time to explain to him what was going on. No one ever took the time to explain his medical condition. He was grateful that he answered his questions and explained to him why he was constantly having these symptoms. He was always coming in with this bronchitis. And he was happy to finally get a referral to a specialist. Hopefully he'll at least be, have some better maintenance of his health conditions versus these chronic exacerbations. Any questions, thoughts, or comments on the COPD fellow here? Any thoughts? Okay. Let's see. Let's pick another one. We've been doing quite well here, pacing-wise. We've already gotten through 2. I'm going to stop screen sharing for just a second. I want you to create some variety in our diagnoses today, so I want to check the diagnosis on this one before we start it. I think I remember which one this is. This one's fun. Yeah, let's do this one. All right. So this patient's chief complaint is unexplained weight loss. I promise you already have a diagnosis in your head when you're thinking unexplained weight loss. You have a couple in your head already. A 36-year-old woman presents to her PCP with multiple complaints: weight loss, palpitations, which are worsened by anxiety about her health for the last 3 months. She is the sole caretaker for her ill mother and has no time for herself or to seek care. She lost 15 pounds even though she nervously eats. The patient states she's stressed and anxious, seeing how the Alzheimer's is affecting her mother, and the patient attributes her palpitations to her anxiety. Okay. Review of systems was positive for weight loss, palpitations, and anxiety. Negative for sweating, heat intolerance, tremors, headache, changes in vision, chest pain, shortness of breath, fever, chills, vomiting, diarrhea, constipation, or suicidal ideation. With the diagnosis I already kind of have in my head, I actually would have expected some more of those things on the review of systems to be positive, okay? The patient's history is significant for a negative screening of depression and anxiety that was done last year, not a smoker. She quit 5 years ago. There's no substance abuse history, sexually active, monogamous relationship with spouse, has children. She's happy with that. Family history is positive for diabetes, hypertension, and CAD. No drugs, no food allergies, takes melatonin, PRN for sleep. We can look at this patient, normal temp, heart rate's slightly elevated, respiration's fine, blood pressure just slightly elevated, weight is 224, BMI is 35, and she has lost 15 pounds within the last about 3 months, even though she says that she's still stress eating. That's one of her preferred copingisms, as we all do. Here's anxious and fatigued, mild acute distress, scored negative on PHQ-9 and GAD-7. She has mild exophthalmos with reactive and responsive pupils with light. What is exophthalmos? Put that one in the chat. What's that? Bilateral conjunctival inflammation noted. She's got a soft, non-tender, slightly and diffusely enlarged thyroid without lymphadenopathy. She is tachycardic, lungs good, abdomen moderately tender throughout. Good. Someone put bulging eyes. Perfect. That exophthalmos is bulging eyes. Extremities, no swelling, neurologic intact. Okay. So what are our differentials? What are we thinking here? What do we think's going on? I mean, this one seems like a good soft pitch that we're going to be able to hit. Probably looking at hyperthyroidism. All right, so there's multiple types of hyperthyroidism, right? Awesome. So we've got multiple types of hyperthyroidism. What are we thinking of here? Good. Okay. So it's going to break down the different types here, which is awesome. Love a chance to break these types down. Hyperthyroidism is, again, one of those things that as primary care we need to catch and screen, but we are going to punt this one over to endocrine at some point, okay? Hyperthyroidism caused by hormone overproduction is high on the differential list. There are multiple possibilities to explore. So Graves' disease, again, is the most common type where the TSH receptor and autoantibody stimulates the thyroid follicular cells to produce excessive amounts of T3, T4. So the thyroid itself starts to become what's in control. It starts to spit out tons of T3 and T4, and that TSH will be decreased because the pituitary gland does not need to say anything. The thyroid has got it all by itself. Hypothyroidism is the exact opposite. The thyroid won't put out any T3 and T4, so our little pituitary gland up here is just spewing TSH. Wake up, thyroid. So high TSH with no results, no T3, T4. So that's kind of your look at your thyroid panel. So toxic nodular goiter is caused by an autonomous hyperfunctioning thyroid nodule that produces hyperthyroidism. It's more prevalent in older adults and in iodine deficient areas and can sometimes coexist with Graves' disease. So this one is got nodules. So we didn't really feel any nodules on this one. Pituitary adenoma can be confirmed with an MRI, should be on the list. But however, other signs of excess pituitary hormones are absent, including galactorrhea or acromegaly. So if the pituitary gland is the problem, other things happen downstream other than just the thyroid being overstimulated. You get galactorrhea and acromegaly because you'll have the increased oxytocin, and you'll have the acromegaly. It's increased growth hormone. So the pituitary gland is going to stimulate additional things other than just the thyroid. So we would want to consider a differential. It would be considered a differential should initial lab work fail to confirm a more common etiology of hyperthyroidism. Thyroiditis, granulomatous, subacute and Hashimoto thyroiditis result in destruction of the thyroid with release of stored thyroid hormone. Hashimoto thyroiditis is the most common thyroiditis, but generally leads to hyperthyroidism followed by hypothyroidism. This transition period is called hashitoxosis. That usually lasts for 1 to 2 months. According to this patient, she's already at 3 months, so it's unlikely that this is the problem. She would have already converted to hypothyroid state if it was Hashimoto. Substance abuse is possible but unlikely. She used to smoke, is anxious, and has tachycardia, all of which are some red flags to list this as a differential diagnosis. However, she denies it. If you couldn't find anything else, you could do a urine toxicology. But again, it doesn't seem like that seems to be the problem. Generalized anxiety disorder. Again, the patient herself just thinks she's anxious because she is going through a life stressor right now. But we do need to make sure that she's got other underlying conditions. I once saw a case when I was in graduate school. I was shadowing, like doing just a few OBS hours with a specialist. And so I was following around this cardiology nurse practitioner, and this physician comes storming down the hall from the other end of the office, just fuming. I'm like, okay, what's happened here? They sent me this patient with tachycardia, and they didn't even do a thyroid panel. She's got hyperthyroidism. And so that's always stuck in my head. When you have a tachycardic patient, don't automatically assume anxiety and don't automatically assume they need to go to cardiology. You need to rule out your underlying causes, including anxiety, before you're shipping them off to cardiology. I have never seen a physician more mad than this guy who got punted a referral that absolutely needed to stay in primary care and then put to a completely different specialist. Like, he just went in there and immediately was like, this is obviously hyperthyroidism. So again, what is the most likely diagnosis here? We're going to go with Graves' disease. Again, most common cause of hyperthyroidism. We've got all the right things for this. Unplanned weight loss. So she wasn't trying to lose weight. In fact, she says she is still eating. Weight loss is not proportional to her eating habits. She has palpitations. It could be caused by hyperthyroidism. It could be caused by her anxiety. It could be a thyrotoxic heart disease. But we need to dig into that further. And then also the orbitopathy occurs in around 25% of cases with Graves' disease. Not everybody with hyperthyroidism has the eye bulge, and I can absolutely confirm this. It's only like 1 out of 4. I have family members with hyperthyroidism, no bulging whatsoever. Just tachycardia for days. All right, pathophys. This one's short enough. Let's hit this a little bit. So Graves' disease is the most common cause of hyperthyroidism, especially in people in the 3rd and 4th decade of life. So we're looking at our 30s and 40s coming in with some of these symptoms. There is generally symmetrical enlargement of the thyroid gland and increased vascularity. Follicular epithelial cells are columnar in appearance and increase in both size and number. That would be if you did a biopsy. The serum of 90% or more patients with Graves' disease contains TSH-R antibodies that act directly against the TSH-R site in the follicular epithelial membrane. This antibody is also called TSI. As it binds to TSH-Rs, it stimulates hormone synthesis and secretion similar to the action of TSH at the site. So it mimics TSH, which is going to make them put out T3, T4. The origin of TSI in patients with Graves' disease remains uncertain, but a genetic contribution is suggested by the high concordance rates among monozygotic twins. Incidence of either autoimmune conditions is frequent, and this underlies a theory that there may be a defect in the suppression of T lymphocytes that allows B lymphocytes to severe antibodies as the underlying cause. And this is a common working theory that's still out there, is that autoimmune conditions, it is completely unsurprising if a patient has an autoimmune condition to have several others. So that's why there's this theory that there is a deeper defect of the T lymphocytes that's allowing the B lymphocytes to sever antibodies as the underlying cause. Okay, what kind of tests are we going to order? What other tests do we want to order for this patient? Put that one in chat. What do we want to order? Anything else? Anything be done in the primary care setting? I don't think we've technically have we gotten the thyroid panel yet? Well, we're going to get a thyroid panel. Here we go. We're going to do EKG, urine toxicology, CMP, CBC, serum TSH, and T3. The results, so the EKG came back without abnormalities except for the tachycardia. We've got tachycardia alone. It's not severe. She was only sitting at like 103, 102. So we're not terribly concerned about this tachycardia. It's probably going to calm down as soon as we get the thyroid to calm down. Urine toxicology was negative for all drugs. TSH level was suppressed with an elevated T3, exactly what we would expect. Elevated levels of thyroid hormone also increase the heart rate as well as cardiac output and contractility. So it's a hormone that increases the heart rate. So that's why we're having slightly elevated blood pressure and a slightly elevated heart rate. Thyroid ultrasound, so this is considered test. Thyroid ultrasound to further evaluate was considered but deferred until a follow-up. If the patient is referred to an endocrinologist, the goiter will be evaluated at that time. So endocrine will absolutely do a thorough examination of that thyroid. One of the more sensitive imaging tests for thyroid disease is radioactive iodine or technetium uptake. The presence of increased uptake indicates increased metabolic activity in the thyroid gland. This diagnostic test is typically ordered by the endocrinologist to determine the cause, but is not necessary for a patient with obvious Graves' disease who has elevated serum TSI or associated Graves' ophthalmopathy. So again, those eyes are very specific to Graves' disease. Again, you don't have to have it to have Graves' disease, but if you do have it, it's likely Graves' disease. What are our next steps? We're going to provide reassurance to the patients. We're going to make a follow-up appointment within 10 days to discuss the lab results. We're going to provide emergency cautions for whether she should go to the clinic or to the ER. In the absence of contraindications such as asthma, bradycardia, or heart block tachycardia tremor, and anxiety can be relieved by taking beta blockers such as atenolol or propranolol. Therefore, a trial of atenolol was initiated. I can definitely treat the symptom until we can get the thyroid to. So the patient agreed with the plan to start the antithyroid medication methimazole at a low dose, 5 milligrams PO daily. Benefits, risks, and side effects of the medication are discussed. Then we're going to refer them to endocrinologists for further evaluation and management. Lengthy education was provided to the patient addressing the areas outlined under the patient education section, which is here. So low dose methimazole, the endocrinologist is going to, again, possibly order some of these tests to further evaluate it and may, again, change the medication around. Because again, one of the harder parts of treating hyperthyroidism is reaching euthyroid status and not suppressing the thyroid so much that you cause hypothyroidism. The goal is to get it to a euthyroid state, but sometimes hypothyroidism ends up being caused, and then you treat it like hypothyroid with Synthroid. What are the cause and clinical manifestations of the diagnosis? So Graves' disease is autoimmune. We kind of talked about that. Overlapping autoimmunity. Yep. The pathogenesis of extrathyroid manifestations such as orbitopathy, germopathy, acropathy, thickening of the extremities, manifested by digital clubbing, soft tissue swelling of the hands and feet, and periosteal newborn formation associated with Graves' disease is poorly understood. So I don't know why that happens yet. Oh, interesting. All right, we'll move on from there, though. What kind of education are we going to give? What are the causes? What symptoms are we looking for? And this is going to hopefully give her a lot of relief. Again, because if we think about the original story for this patient, having a cause for all of her symptoms, it's not just her life situation right now. There is a treatable cause for some of this that she's experiencing. So I contacted the patient as soon as the abnormal results came in and advised her to return at her earliest convenience. The labs were discussed, treatment options explored and explained, beta blocker and antithyroid drug were proposed. The patient agreed with the plan to start the low-dose methimazole while waiting for a referral to an endocrinologist. Again, in my opinion, nothing wrong here with referring to the endocrinologist because you're going to refer either way. So if you're not comfortable with starting the methimazole, it is okay to refer them to endocrinology. I was the PCP for this patient and her family for a couple of years. But so if you're in an area where, like everywhere, referrals are going to take forever, low dose is better than nothing. I was the PCP for this patient and her family for a couple of years and was well aware of her mother's health and the daughter's role as a caregiver. This was an important opportunity to listen attentively and reassure my patient and refer her to a social worker. The phone call was a personal touch that I showed care about her worries and distress. Empathy, reassurance, and timely communication are often overlooked because if you think about that timeliness aspect of it, especially coupled with electronic charts these days. Sometimes, think about the patients sitting there waiting for you to call them. You're seeing 40, 50 patients within the last few days, but they're sitting there waiting for you. They're one provider. You have many patients, but they have one provider, and they're just sitting there waiting for that phone call from you. And then electronic charts are showing them their results before we ever get a chance to talk to them. So they're seeing these abnormals, panic Googling, finding these terrible answers to their healthcare questions without a provider explaining and caveating and nuancing in with all the other data that we've collected about what's going on with the patient. So I think that's one of the harder parts, is patients being able to see their lab results kind of immediately, and the panic that can truly cause. It really can, because sometimes we can look at a lab panel and be like, oh, that's obviously needs to be redrawn. There's no way these labs can be this bad with this patient sitting in front of me. So it's just difficult. So that timeliness, I like that they mentioned that here. The patient started a course of methimazole at the lowest dose. It helped settle her palpitations and weight loss while waiting to see the endocrinologist. 3 months later, the patient returned to my office. She had gained her weight back. Her heart rate returned to normal. Endocrinologist assured her of no other complications. Patient was calmer and stated she could now devote herself into taking care of her mother without stressing about her own health conditions. Also saw a clinical social worker. She was able to better recognize, identify, and manage her stress. They monitor her TSH every 3 months, adjust meds accordingly. She was excited. Her hands were no longer trembling, and tell her everything is going to be okay. That's really good. All right, any questions on the hyperthyroid patient we had here? Any questions or thoughts on this lady? All right, this one I'm going to kind of go ahead and give away the answer, because we're going to do a case study on testicular torsion. But this one is, one I wanted to go through just because I wanted to kind of dive deeper into testicular torsion. Every now and then I'll run across a diagnosis and be like, I understand that. I know what I think about it. I know how to manage it, but I want to know more about the why. And so I found this case study recently. I've actually already read it, but man, it really explains some things about testicular torsion that I don't think I've gleaned from previous study. So we have a 23-year-old male with no past medical history present with sudden onset of left groin and scrotal pain. He reports that his symptoms started approximately 45 minutes prior while playing basketball, which is a typical timing for a testicular torsionist during a physical activity or sport. The pain has been constant without relieving factors. Patient states that he has tried rest and ice, no improvement, no discharge, dysuria, or abdominal pain, but does complain of nausea and 2 episodes of vomiting. Also very common. This is a remarkable painful event as necrosis is occurring. Anytime we cut off circulation to any part of the body, pain and nausea and vomiting is right there. Examination, high heart rate, high respiratory rate, but blood pressure elevated due to the pain. O2 is fine. Abdominal exam is significant for mild left lower abdominal tenderness. Examination of the left scrotum demonstrates mild swelling and erythema with an absent premasteric reflex. What is the premasteric reflex? Put that down in chat. Palpation of the testicle is difficult secondary to pain. However, it is slightly more full than the right and slightly higher. The remainder of the exam is unremarkable. So this is kind of a section that I don't think I'd really ever grasped before about what exactly is going on, what causes torsion. This was just absolutely fascinating. Testicular torsion is a result of the twisting of the testes and spermatic cord within the scrotum, with resultant occlusion of venous return and edema. If the torsion persists, it leads to occlusion and ischemia. Ischemia leads to infarction, and then this can also result in decreased fertility due to the loss of the testicle. Treatment of testicular torsion is a true urologic emergency, so diagnosis and management should not be delayed. So, why is this twisting? Shouldn't something be holding it down? Yes. Normally, the testicle is anchored within the scrotum by the tunica vaginalis, which surrounds the testicle and attaches posteriorly to the scrotal wall and the epididymis. The tunica vaginalis consists of a visceral and parietal layer with an interposed potential space. This potential space allows the testicle to rotate about the spermatic cord within the tunica vaginalis if a firm posterior scrotal attachment is lacking. So if the attachment is long or lacking, then it's kind of freely moving about this space. It should be tacked down. If for some reason it is not tacked down, it can twist. The tunica vaginalis attaches higher up. The testicle can move and twist within the scrotum, creating the bell clapper deformity. So it's normally sitting more like this. If it's attached improperly or is not attached at all due to a traumatic event, twists on the side, and we've got the bell clapper deformity. This places the testicle and spermatic cord at risk for torsion. The appendix testes are embryonic remnants that have no known function and are located on the upper pole of the testicles. The appendix testes are prone to torsion as well and present with symptoms that mimic torsion of the testicle. Still got to refer because you can't tell. So what do? We perform a focused history and physical exam, pain control, ordering or performing ultrasound, and consulting urology. If you're in the outpatient setting, you are performing a focused history and physical examination and then tossing them in an ambulance. Or I'm a big fan of taking the car if you trust the family and we're 4 minutes from the hospital, because it's just, you can get there. We're not needing like a defibrillator or something like that. It's okay to send patient in the car if they understand. If you don't go, and they're going to go, if you don't go, this is what's going to happen. So what are our differentials? Testicular torsion of the appendix testes, which is again that embryonic remnant with no function. But again, since it mimics it, you still have to treat it like it. Epididymitis, orchitis, renal colic, varicocele, appendicitis, hernia, hydrocele, testicular trauma. So what is a typical classical or classic presentation? Although it can occur at any age, testicular torsion is most common in the first year of life, including the prenatal period and at puberty. So this is definitely a young man's condition. Patients should be asked about the timing and if there is any associated urinary symptoms, fever, or trauma. Patients often describe fairly sudden, severe, unilateral testicular pain that radiates into the abdomen, associated nausea and vomiting. Left testicle is more frequently affected. Torsion may result from direct trauma, and the diagnosis may be delayed if they think the pain is from the injury itself rather than the torsion. A small number of patients will describe intermittent testicular pain that resolves spontaneously. So this history is highly suspicious for torsion and detorsion, but this should be referred promptly to a urologist to avoid an acute torsion and testicular ischemia and loss. A lot of patients won't know to provide that information during a sports physical or a wellness exam, but if they mention remitting pain in the testicle that's kind of coming and going spontaneously, that is something you would want to refer to urology. On physical examination, the patient is often in significant distress and may have trouble walking due to severe pain. It is severe pain. The physical examination may be very difficult to perform, lots of discomfort. Examine the unaffected testicle first in both the supine and the standing position. Affected testicle is exquisitely tender and swollen. Again, it sits higher within the scrotum than the unaffected testicle and may have a transverse lie. Prend sign describes the relief of pain with elevation of the testicle. Though this was once touted as a method to distinguish between epididymitis and torsion, since the pain with torsion is usually not relieved with that elevation, Prend sign is considered unreliable in differentiating between the two entities. So several studies have found loss of the cremasteric reflex to be the most accurate sign of testicular torsion. So this reflex is elicited by stroking the ipsilateral thigh, which leads to a reflexive elevation. But this, again, is not present in a patient who has testicular torsion. There is no rise that should be seen. The inguinal area should also be examined for hernias. So diagnostic testing, again, at this point, we've sent them. We're in the ER. Laboratory analysis of blood and urine is usually not helpful. Infectious epididymitis or orchitis is suspected, then it is reasonable to perform a urinalysis and test for gonorrhea and chlamydia. Caution should be exercised, however, since as many as 30% of patients with torsion will have white blood cells in the urine just because we're having trauma inflammation. Regardless, the management of suspected torsion should not be delayed for any lab results. You're keeping on progressing as if it is a torsion. Ultrasound is the test of choice in the ED to diagnose torsion when clinical diagnosis is not clear. Comparison of the painful testes to the asymptomatic one is key. The painful testicle is usually enlarged and hypoechoic with decreased blood flow compared to the asymptomatic side. Twisting of the spermatic cord may be visible on the ultrasound. In contrast, epididymitis is usually associated with increased blood flow. Okay? So here's a right and left. Side-by-side US with Doppler imaging. Note the decreased Doppler flow of the left testicle indicating a torsion of the left testicle. Okay. So we've got blood flow, no blood flow. How do I make a diagnosis? So testicular torsion is primarily a clinical diagnosis. Classic symptoms: sudden onset of pain, diffuse swelling and testicular tenderness, loss of cremasteric reflex. You can have a presumptive diagnosis without any further testing. However, if the presentation is less classic, a urinalysis and Doppler can be performed. Table 1 summarizes some of the difference between testicular torsion and two other common causes of an acute scrotum: torsion of a testicular appendage and epididymitis. So go ahead and review that one. Kind of look through those there. You can take a picture. Definitely helpful. Definitely about the age of the patient. While ultrasound is the most useful diagnostic modality, definitive diagnosis is only made through surgery. Do not delay calling the urologist if you suspect torsion. So it is treatment, again, going to the ED. If you're the NP in the ED, because again, FNPs are the type of NP that's typically hired into the ED, so you may be the receiving end here as well. You're going to do your ABCs, because you at this point, you're saying, all right, I got to prep this patient for surgery. I'm assessing them to make sure that we're appropriate for surgery. Treat the pain, treat the nausea, keep them in PO. Then there's other things here. There's specific positionings and things like that you can put the patient in. So you could attempt a manual detorsion. So you would place the patient in a supine position and stand facing the patient's head. To manually detorse the testicle, grasp it gently and rotate it away from the midline as if you were opening a book. So away from the midline, opening a book. Most torsions involve one or more complete rotations, often up to 720-degree rotation. So it may need to do 2 or 3 complete rotations of the testicle. When the maneuver is successful, the patient reports dramatic pain relief within minutes. The lie may normalize and blood flow should be restored. So your immediate thought there is, okay, why don't we just do that on all patients and then just move on? Well, if it's not tacked down properly, it's just going to retorse. So this is only to save the testicle, basically, and maintain fertility, stop the pain if we don't think that the patient's going to get into the OR quickly enough. So in a few amount of patients also, you need to twist the other way. Most of the time it's twist like a book. Sometimes you may need to twist inwardly. So keep that in mind. So definitive treatment is still surgical. Even if it is untwisted, we do need to still tack it down appropriately. Okay. So we need to do this and perform to prevent future torsion and preserve that fertility. Okay. What are our pearls and pitfalls? Making sure you call that urologist immediately, even before the ultrasound is obtained, if you have a clinical diagnosis. Non-viability occurs in as little as 6 hours. Consider torsion in any patient with testicular trauma who still has pain 1 to 2 hours after the injury. At that point, it's no longer, okay, you've gotten kicked. Ouch. We're still hurting 1 to 2 hours later. That is more likely going to be a torsion. Again, it's primarily a clinical diagnosis. You do not have to get an ultrasound on all patients. Do not delay management of the patient if you can't get an ultrasound on them immediately. This one is, hear the hooves clacking down the hall. We need to follow it. It's probably testicular torsion. What is the resolution? You attempt a manual detorsion with some improvement in pain. Within 5 minutes, the pain is already returning. This testicle just wants to twist. The ultrasound is performed. Ultrasound demonstrates decreased blood flow, twisting of the cord. Urology is consulted, patient taken to OR. It is successfully detorsed and affixed to the scrotum. So that wraps up that guy right there. Any questions on testicular torsion? I'll go ahead and we're going to put that case study right here because this one's not inside of that book. You wouldn't have to have access to the like online book to see this one. So there's that case study. I put it in the chat if you want to open it up and save it and look more deeply at the chart here. I love charts that help us kind of describe our differentials and work out between those. All right, so we have done, I think, 4 case studies now. And I can definitely feel myself starting to get hoarse. What questions or thoughts do you guys have so far? And start my share there. Any other thoughts or questions? Okay. I'll open up the floor now to other questions, anything kind of you want to ask. So we've gone through our 4 case studies that I anticipated us going through. So again, what I have typically done in the past for students is I have done mentorship, I've done tutoring, I've talked about boards, like how to prepare for them, how to study for them, how to like get through pharm, how to get through the 3 Ps, what you should be prepared for clinicals, kind of my tips and tricks about how to make your clinical day a little bit easier. So if there's anything there that you want me to talk about, any burning questions that you have, please put that in the chat or ask me with your mic on, and that will give me something that we can talk about for maybe the next 10 or 15 minutes before we wrap up. If not, I might be persuaded to do a 5th case study. We'll see. What about non-clinical topics for boards? So there's a section in, actually I've already talked about this twice today. I've had like 3 other Zooms this morning for counseling. I have talked for like 4 or 5 hours today. So this book right here is definitely kind of the one that I recommend if you want to talk about non-clinical topics for boards. So that would be only if you're taking ANCC, right? So if you're taking ANCC, there's going to be 10% of the questions are going to be non-clinical. And so this is one of the only resources out there that really actually includes it well, in my opinion. Most of the other resources, board preppers, everybody doesn't really include much of it. So it's in section 7 of the leak book. It's the section called Professional Role Review. And that's chapters 26 through 30 in the 4th edition. And the topics under non-clinical topics is ethical guidelines, advanced practice law, professional role and reimbursement, cultural and spiritual health beliefs, nursing research, evidence-based medicine, and epidemiology. And so those kinds of topics are talking about, okay, what's the different types of parts of Medicare? So Medicare Part A, that's inpatient hospitalization. Part B is outpatient. Part C is Medicare Advantage. Things like that. Part D is the prescription drug benefit. How do you get Medicaid? What is CHIP? What is case management? Different types of, I think they talk about like HMO, PPO. Yeah. What is HMO? With HMO, you're assigned a primary care provider who's the gatekeeper. With PPO, they can visit any provider within the network. So that's ethical guidelines and practice law. Some examples of topics within professional roles and reimbursement. How to manage a prescription pad, what are prescription privileges, what is considered a controlled substance, what's a Schedule II, what are rules about e-prescribing medications, electronic prescribing. What is an ICD-10 code? What's a Z code? The Z code is all of those wellness encounters. What's a CPT code? 5-digit code used to identify medical procedures. What are E&M codes? That's like the difficulty level for the visit type. That's an example there. So that's kind of the resource that I would recommend if you want to look at kind of the non-clinical topics. It's the drier stuff that you probably didn't learn about too much in school, but maybe got exposed to some in your clinicals. And I would recommend, like, you could put it on note cards. It is one of the few things that I would say note cards is okay. Most things that we're learning at this level are too complex to put on a note card. A lot of this stuff you could use either Quizlet, make yourself a deck, or physical note cards. I'm the type of person, if I write it down, it helps me remember it. So that's how I would approach studying for those non-clinical topics. Great question. What other questions might we have? If not, I'll do a bare bones case study where we'll skip through some of the more complicated portions and just kind of get right to the diagnosis. Do you guys want to do another case study? Yes? Or any burning questions? Joanna says yes. Joanna's convinced me. All right, so let's look at a kiddo. We haven't looked at a kid yet. So itchy bumps. A mother brings her 9-year-old daughter to her PCP for evaluation of an itchy, bumpy rash that comes and goes but resolves within a few hours. This has been going on for a month. This is fun. The last episode of a rash was one day ago and lasted all day, keeping the child and parent up at night. The rash was accompanied by a swelling of the girl's eyelids. The mother administered diphenhydramine at night, which helped a little. Today, the eye swelling has resolved and the rash is slightly better. The mother was able to take some pictures of the initial rash with her phone. This is a place where pictures are very helpful. Like anytime one of my own children pops up with a rash, I start taking pictures because they change. Rashes do change with timing during the course of an illness. So I do recommend and appreciate when a parent takes pictures of rashes to show the progression, where it was earlier, where it is now. So the rash in the pictures shows raised bumps and patches, round or oval across the body, especially on the abdomen, thigh, and back. The patient remembers having a few itchy bumps here and there in the past, but thought they were mosquito bites. The patient and mother cannot recall a correlation between rash and possible triggers such as food, contact, or other stressors such as heat, cold, or medications. She is extremely concerned as she has tried to find answers online and worried her child may have cancer or leukemia. The mother is unsure of any food allergies. So you'll see that a lot of the questions we need to ask when skin shows up is timing, exposure, anything that we can find environmentally to correlate this to. So the patient's review of systems is positive for diffuse rash, pruritus, and upper eyelid swelling. Her ROS is negative for unexplained fever, adenopathy, weight loss, fatigue, headache, joint pain, swelling, wheezing, flushing, palpitations, abdominal pain, skin ulceration, wheezing, shortness of breath, and swelling of throat or tongue. She has no history of thyroid dysfunction, vasculitis, or autoimmune related health problems. The patient has a history of seasonal allergies to pollen and takes loratadine 10 milligrams daily during the spring and early summer. Up to date on immunizations. No significant contributory history from her family. No known drug allergies, no food allergies. Takes loratadine, Claritin as needed during her allergy season. Okay, let's look at her here. No fever, heart rate good, respiration's good, blood pressure expected to be that low at that age. BMI 18. Alert and oriented, playful, and interactive. You'll often find that general exams for children will, say, how are they acting? Because play is such an important feature of childhood. If they're not playing or making eye contact, those are definitely concerns for if this kid really doesn't feel good. So playful, interactive, that's kind of the standard norm for 9. Okay. Normal eye contact, normal affect, good eye contact, answers questions appropriately. This is where we're going to spend a lot of our time with this chart. So no lesions or scales in the hairline, diffuse, raised, erythematous, and edematous papules and plaques, ranging from 0.2 centimeters to 1 centimeter, present on the neck, abdomen, thighs, legs, arm, hands, feet, buttocks, and back. So pretty all over, right? Plantar and palmar surfaces are spared, and that is an important thing to chart, okay? Most rashes do not go after plantar and palmar surfaces. So this is a relevant, pertinent negative, because if it was there, it's only going to be like one of 9 things. If it's not there, you can exclude those 9 things, but it lets you know it's like everything else. Lesions are blanchable, no ulceration or target lesion noted. No jaundice noted, skin normal turgor, no abnormal findings with the hair or nails. Let's see. When we're looking at skin, we want to look at the sclera. So we've got normal sclera and conjunctiva. Ophthalmoscope exam shows no signs of hemorrhage. TM's clear, oropharyngeal mucosa without redness or exudate, no swelling. Neck is non-tender, no adenopathy. Lungs good, heart good, good perfusion throughout. So what is our differential diagnosis here? We've got a few here. We've got pityriasis, rosea, urticaria, angioedema, contact dermatitis, scabies, and insect bites. Pityriasis rosea is an inflammatory skin condition that presents generally as a single lesion called a Herald patch, followed by multiple papulosquamous lesions that can be itchy. It lasts up to several weeks and is self-limiting. This is inconsistent with the patient's rash, which covers much of her body. And that was one thing they mentioned here was no target lesion noted. So this patient doesn't have that, what we call the Herald patch. So let's pop the images here. Here's our Herald patch. Okay. So this patient has this rash all over, but we have one patch that is different from the others. Am I screen sharing that? Good. Sometimes I'm screen sharing just a tab, but urticaria has a subacute onset and is episodic in nature. It's pruritic and migratory. This is high on the differential given this patient's presentation and recent history. What are you guys already thinking? Like, what are you thinking is causing this? It seems to have some interesting timing and cycles to it. Angioedema in children is typically associated with urticaria, which may or may not be present with this condition. The patient has swelling on the orbital area and lips and tongue. The patient does not present with this finding today, but has a history of eyelid involvement. Therefore, this diagnosis must be considered. Contact dermatitis is a localized reaction of itching and burning, may have swelling or formation of blisters. This child has a generalized rash, pretty much whole body, suggesting that contact dermatitis is less likely. Scabies rash can look generalized, but is usually papular with burrows. Additionally, scabies rashes often has moderate secondary excoriations. They scratch. This is an unlikely diagnosis based on the patient's presentation. Y'all had a family of 6. It was either 6 or 8, I don't remember exactly, with scabies. That was a very long day because I had to create charts. I worked in walk-in. I had to create charts on all either 6 or 8 of these people so I could prescribe them all the same medication. Oh my goodness. And I literally closed down that. We had 2 offices. We used one for either like storage or breaks. It was still perfectly clean because sometimes you'd have a second provider. And you'd use the other one to see your patients. Yeah, I closed down that first one very quickly afterwards and went to the other side for the rest of the day and then like put my clothes in a bag for a year. I just was like, oh my goodness, I cannot believe. It was such a large family. I felt so bad for them, but I knew that after they got their medicine and went through their treatment, it was going to be okay. But it was definitely one of those memorable things. That took the poor gentleman so long to check in his family that it timed out before it let him check him in because you could check in as a group. And so he was trying to check in as a group of 6 and the computer system times out after 10 minutes. And so he spent all 10 minutes typing in every single person's information for it to time out. And so then I had to go in and do it individually for each patient. It was such a long morning. It was my first thing too. It was like a Saturday at 10 a.m. and it took me an hour and a half just to see these 6 people. All right, so that was my side scabies story. Insect bites can produce a rash that mimics urticaria, especially when multiple small bites are present. There may be small hives at the bite site. This is unlikely because there doesn't seem to be like an infestation of bugs in their house, and it's been coming and going for a month. So what's our most likely diagnosis? You guys tell me. Which one of these is your most likely diagnosis? Any guesses? Okay, urticaria. So urticaria with reported angioedema. So both. The patient's not presenting with the angioedema right now, but the pictures indicate to us that they have had angioedema. This rash has a subacute and episodic onset, wheals, plaques, and erythema with pruritus and is migratory in nature. The most common underlying cause of urticaria in children is viral or bacterial infections, food allergies, gut parasite, Helicobacter, H. pylori infection, or atopy. So what kind of diagnostics are we going to want to order to kind of help us find our root cause? What kind of things do we want to do? That's all the mast cells and H1, H2 that's related to urticaria. So what kind of things are we going to do? We're going to do food and inhalation allergy panel serum tests to rule out any allergies. This patient's blood test revealed multiple food allergies: grain, dairy, fruits, and vegetables. So we have lots of things going on with this kiddo, which explains the kind of remitting and migratory, especially the remitting and exacerbating, because whenever they're being exposed to the food that's causing their problems, they're having an exacerbation. So what do? We're going to do an H1 blocker. I'm a fan of Zyrtec. And then diphenhydramine can be administered at night. You can also do a burst of prednisone if it's severe. If they fail, then they need to be referred to allergy immunology. Consider an epinephrine pen for this person as well. Repeated exposures to things one is allergic to can result in anaphylaxis. So they can at any point kind of develop an anaphylactic reaction. So having an EpiPen on hand is important. Journaling can also be helpful of finding common triggers that might not have been included in the allergy panel, because there could be additional things in the environment or food world that is bothering them. So journaling reactions, and a follow-up appointment to go over the labs and reevaluate. So again, all the allergies detected on the serum test were discussed. Because of the multiple allergies, it's going to be a little more complex. They're going to be referred to an allergist. So urticaria is a common skin condition, but the cause is often difficult to determine. Evaluations should be carried out with a specific test selected based on a patient's history. Each case is different, so extensive and expansive laboratory testing is not recommended, as it does not change the prognosis or management. Understanding the pathophysiology and causes helps clinicians improve diagnosis and management. It is challenging because there are other similar conditions: urticaria pigmentosa, urticarial vasculitis, atopic dermatitis, contact dermatitis, drug eruptions, erythema multiforme, Hennig-Schonland, purpura, scabies, and viral exanthema. During the diagnostic approach, PCPs should keep in mind that there are similar conditions that present like urticaria. Acute urticaria reaches self-remission within 3 weeks. About roughly 20% progress to chronic conditions. And she fell into this because she was having the, hold on. Oh, thank you, whoever turned on closed captioning. PCP should keep in mind the duration of chronic urticaria typically lasts 1 to 5 years, but may last greater than 5 years in 14% of cases. Kind of education we're going to need, obviously avoiding the triggers. And then we'll come down here to outcome and insight. So the patient's blood test revealed multiple allergies to grains, dairy, fruit, and vegetables. The patient was started on treatment cetirizine oral tablet and referred to an allergy specialist. I said they switched her from loratadine to cetirizine for insurance purposes. I have 2 problems with that. Cetirizine is better than loratadine for this case. Like Zyrtec is kind of the go-to for urticaria, mast cell issues, these kinds of things. And insurance doesn't really matter here necessarily because cetirizine is available over the counter and fairly affordably. Like you can get 365 tablets for $10 on Amazon, which I can guarantee you is going to be cheaper than almost every insurance plan out there, because they're going to give you either like a 30-day or a 90-day supply with a copay for lots of situations. So if you have a patient who has to be on long-term cetirizine, getting them to go on Amazon and get their or Sam's Club or Costco. Walmart, you're going to pay like $20 for a 90-day supply. But if you're going to like Amazon, Costco, or Sam's Club, you're going to be able to get a lot. For people who don't have, like a Sam's Club or Costco, that's why I recommend Amazon, because almost everybody knows somebody with an Amazon account that could get it for them if they needed them to. Side note, I worked with a lot of self-pay patients, so I know the costs of lots of things at lots of places at this point. Between looking things up on GoodRx and Googling and crowdsourcing and trying to find the cheapest solutions for people, lots of self-pay, just because of where I am geographically. What else? Okay, the patient was started, right. Okay, she is going to be doing immune desensitization therapy. They saw her back 4 months later. She seemed happy. The desensitizing therapy was helping. She was pleased by the treatment plan provided by the allergy specialist. Insight from the PCP. As the PCP and family health provider for this patient, I was well aware of her medical and social history. My suspicion of food allergy was accurate given her symptoms. I explained to the mother and patient the blood test results and printed a list of foods to avoid. I also provided a list of alternative food items to aid in the transition to a new diet. I gave her 2 EpiPens, one for school, one for home, demonstrated how to use it, also the necessity of calling 911 after using it. Made sure that the mother and child were at ease and left satisfied with care. Clear communication coupled with providing resources needed for self-care goes a long way to ensure patients and their families see you as someone who's truly concerned about their well-being and on their side. And it's definitely important to not seem like the adversarial thing that's telling them something bad, but like coming alongside and being like, hey, let's look at this thing that's kind of a little scary, but let's break it down into something small and digestible and manageable, rather than being like, hey, here's this bad thing that's coming at you. Come alongside them and be on their side. I like the way that that's worded there. All right. Whew. That was fun. Last one for sure. It is 10 o'clock my time here now on the East Coast, so I'm ready to snooze. All right, any last minute questions? I'm happy to stick around for a few more minutes if you have anything you'd like to ask. If not, I will upload the recording of this to that same class that was uploaded there. It'll be just right underneath it. It originally said coming soon. So good question from Joanna, and I actually anticipated that question. It does look a lot like ringworm, but with ringworm, you're really only going to have like one patch, and that's your ringworm. With pityriasis rosea, you're going to have a herald patch, and then a ton of other lesions as well, which would be the confirmatory or the clinical presentation for pityriasis rosea. Good question. Okay, anyways, I'll upload the recording. It'll be, again, in that same class just below where the link was previously. Feel free to check out the other classes that I offer as well. They're got a SOAP note class. It's got case studies as well involved in it. In fact, I'll probably upload these into that class as well, just so people have it all in one place. But I'm looking forward to doing some of the other courses that were kind of listed on that poll, including the AAA pharmacology, which would be antibiotics, antihypertensives, and antidiabetic medications. And I haven't done pediatrics in a while, so I'd love to do an updated pediatrics course. That's about a 2 to 3 hour lecture, and just get some new practice updates involved with it, add some more content to it, and hopefully we'll do that one in July. So the other two, we'll probably do those in July. But I hope you enjoyed tonight. Hope you have a good evening and a restful weekend. Bye.